Hey everybody, Gray Stahlman. I'm your host. The doc is in. Live with TOA is back in the house. It's Friday. We're back in Nashville on a regular routine Friday afternoons. This is Dr. Blake Garside. We'll be talking to him in just a second. Little history. Dr. Garside and I have been friends since we were residents way back in the dark ages, and we've been friends ever since. So I'm looking forward to our talk today. I'll tell you a personal story about him later. But today we're going to talk about meniscus tears, and I'm going to have Blake tell us all about that. But just remember that as with all of our episodes, this time is to give you information. It's not to give you medical advice. We are fellowship trained orthopedic spine surgeons, but we're not your spine surgeons. He's not a spine surgeon. I'm a spine surgeon. Sorry, I'm losing my mind. We're orthopedic surgeons, but we're not your orthopedic surgeons. So please don't consider this medical advice. Basically, information for information and educational purposes. Okay? If you have a problem, whatever it is, musculoskeletal-wise, your bones, muscles, joints, and nerves, go to TOA.com. You can find out about what we can help you with, what services we offer, where we are, what we do. We have a whole slew of informational videos in our media center. So go to TOA.com and let's get you some help anyway. So without further ado, Kevin and I would like to this is Kevin, by the way. We'd like to welcome you. Blake Garside is an orthopedic surgeon, superb orthopedic surgeon. I say that with personal experience. Thanks for being here.
Thank you.
We're going to talk a little bit about meniscus tears. So before we get to that, why don't you tell everybody kind of about yourself, what you do, what you like to do, whatever your interests are.
Well, like Dr. Stahlman, I finished my training in 1995. I've been an orthopedic surgeon since finishing my fellowship in 96. And my specialty interest is with primarily shoulders and knees. I do a lot of arthroscopic surgery in addition to joint replacement. But first and foremost, I see a lot of patients with knee injuries. I see them with shoulder injuries, but knee's been one of the passions and my main interest because of the multiple procedures. I like the procedures, I like the pathology, and and you can typically help patients with it.
Yeah, it's a good way to get positive results.
Positive results.
Right. So we're going to talk about meniscus. So do me a favor. I see you've got a model here. Why don't you tell everybody kind of what the meniscus is, what it does, and why it can be such a problem?
Okay. So if in this model, this is the way that normally you'd see your knee, and you'd have the skin, the muscles around here. So if we were able to pull the kneecap down, between the thigh bone and the leg bone is the meniscus. Now, a lot of people refer to that as the cartilage. So it's it's really meniscal cartilage. And the meniscal cartilage is like a bushing between the thigh bone and your leg bone. It helps stabilize your knee in rotation, and it decreases the force pressure between the femur and the tibia. So it provides for stability. It provides for shock absorption, and those are the main functions. Now, there are a lot of ways that you can tear the meniscus. Or meniscus, when we think of problems with meniscus, a lot of it can be either activity related or degenerative over time. My practice is sort of mixed, so in younger patients you may see somebody who's been running, playing soccer, basketball, or any sort of sports can injure their meniscus through a twisting type event, or where their foot's planted, or over time having some sort of struck from the side and lead to an acute injury. Also, what we start to see in 40, 50, 60-year-olds, we can see degenerative tears of the meniscus. It's done well, and they may have had a small tear in their younger years, and then with continued use, continued activity, staying active, trying to do things, that tear has gotten bigger and then starts to cause symptoms and problems with function.
So that was my experience. I tore my meniscus the first time running, and then the second time, which Blake got to operate on, I wasn't doing much. I don't even think I was doing anything, maybe hiking or something like that. But it's a painful deal. So what kind of symptoms do people have with a torn meniscus? How might they think, oh, it's not just a sprain or something like that?
A lot of patients are going to get recurrent swelling, it's not so much that their knee blows up and they feel it, but it just feels tight. They may notice that it's, say for instance this is the right knee, that they're feeling tighter on their right knee than their left knee with activities. They may have trouble with certain activities, like they don't have a problem when they're going forward or walking forward, but twisting, changing direction, squatting down is one of the things that gets them. I mean, I have a lot of patients will tell you, you mentioned hiking, you don't think of hiking, you're just going, you know, straight forward, but every time you take a step, and when your knee's bent, there's rotation between your upper leg and your lower leg. So that aggravates or exacerbates a meniscus tear and can lead to meniscus tear. So when you get in some of those cramped situations, like for prolonged hiking or going up or down hills, that may lead to symptoms. So you have swelling is one of the first things you think about. Giving way. It's very common for someone to say, you know, I was just walking along and I turned, changed direction, my knee gave way. Well, a lot of that can be a reflection of a pain response, or it can be a reflection of the meniscus tear is displacing and moving to a different part of the joint. That can lead to the giving way symptoms. Other ones will talk about their knee locking, where the knee goes, they're doing an activity and then suddenly they can't fully flex or fully extend and it's blocked. And that's a very common symptom. So we classify locking, giving way, pain, swelling as more of the mechanical symptoms. So we're looking for mechanical symptoms to help give us a history and lead us sort of in that direction for what the diagnosis may be.
Yeah, and in my experience, you know, there's also a pain component, but pain can also be associated with other structures like arthritis or
Yes.
Ligament injuries and whatnot. However, in my case, mine was the right knee, so it's this one. I had what's called a medial tear, which is on the inside part of the knee, and I could point to it right there and say, man, it really hurts right there, and right in the back is where it hurt a lot too. It was really quite specific.
A lot of people will get, and a lot of people can't understand, well, why do they get pain in the back? But you can feel it when, let's look back at our model. In the front, you have your kneecap, and then you have your kneecap tendon, all of which are solid structures. Along the side, when you go right along the joint line, it's fairly specific. The only things along the joint line are your meniscus until you get to your ligaments on either side. Then patients will have pain in the back because of the solid structures in front and then to the sides. The only place for swelling to go is typically either up above the knee in the suprapatellar, what's called the suprapatellar pouch, or in the back of the knee, back here, because there's a space and a capsule, and it tends to distend the capsule and lead to pain that way. And it also is sort of a reflection if they have if they're having pain along the back part, that helps you give you a little bit better localization of where the tear might be.
So how do you make the diagnosis? How do you figure it out?
Well, I typically start with plain x-rays, because like you said, there are other diagnoses that can cause pain. You want to make sure the patient doesn't have arthritis, doesn't have a fracture, or doesn't have anything else going on with the bone. If that's normal and I have a physical exam that's consistent with or suggests a meniscus tear, you'll get an MRI. And an MRI is a special diagnostic study that really looks at soft tissue. Its primary thing is going to give us the best views of the meniscus and also the ligaments. It also shows some bony detail, especially on the cartilage surfaces as they've gotten better over time. But it is a non-radiation entity that sort of outlines all the structures of the knee and tells us, can show us where a tear is, location of the tear, size of the tear, and helps us predict whether it's one that's more degenerative, more acute, and it also lets us look at the surfaces and say, well, you know, gives us some predictability.
I'm gonna softball this one to you, but this is one of my pet peeves. Is a CAT scan a good test for looking at a meniscus tear?
No, it's not.
Okay.
Not at all.
Yeah. So beware if you twisted your knee and you have pain in your knee and it doesn't look like there's a fracture. Don't let the emergency room doctor or your primary doctor order a CAT scan. It's kind of a worthless test.
Unless you have a pacemaker, which precludes you getting an MRI. And then if you do get a CAT scan, they need to put dye in it needs to be an arthrogram because they need to inject it so it will outline those structures that we talked about, because the CAT scan is going to show you great bony detail, but it does not show you soft tissue detail, which is what we're interested in.
So that's one of my pet peeves, of waste of money and time. So anyway, so you diagnosed a meniscus tear. Tell me kind of your thought process about how to manage it. Now, I suspect that it's probably different for a young traumatic person rather than a 60-year-old, some arthritis in the knee, degenerative process. So kind of go through your thought process of how you manage those various different types of things.
So I look at first and foremost, I look at the mechanism, how the patient tore it, what they were doing, age and activity level of the patients, what's it keeping them from doing? Because a lot of times, we have some that we diagnose on our own that come in, and we have some that get referred to us, and they've come with an MRI that shows, oh, I've got a meniscus here, but they're not having any real symptoms related to that. So you have to break it down. So I'm looking at their age, how it impairs their function, what's it keeping them from doing, and then what are other problems they might have. Do they have some mild arthritis? Do they have some instability of their ligaments? And that helps define it. If you have a younger patient with an acute tear, if it's more of a radial tear, which is more signs of looks like the spoke of a wheel. So if you think of it, the bushing is a C shape, and if it runs from the inside to the out, yeah, that's one.
Yeah, so the bushing is like this, and it's a tear across the.
Yeah, you're more likely to try and go in arthroscopically and fix that tear. You also, if you have a longitudinal tear, or one that runs this way, straight up and down, and it's out near the periphery, you're going to look at fixing that, because that actually has the meniscus is predominantly in avascular structure. So if it's torn in the inner 2/3, that typically won't heal because it doesn't have a blood supply. I could go in and put stitches in it all day long, and it would still just continue to tear further because it doesn't have the ability to heal. But on the outer aspect, the outer third has a blood supply, and so in those type of tears, and in a patient who's is young enough, healthy enough, and doesn't have other existing problems in the knee, that's one that you consider fixing it rather than going in and taking it out. Then I sort of break it down and say, what the degenerative tear? What do you do with as you said, a 60-year-old who has some early arthritis? Well, I look at that. You may try some therapy. You look at what their motion is. Were they having some symptoms before they started developing mechanical problems? Do they lack a range of motion? Is therapy an option for them? Might try some anti-inflammatories, and may try an injection just because they were doing some increased activities. They've had the tear for a while, and it was those increased activities in the face of some mild arthritis that led to increased swelling, and you can calm it down with an injection, and they're able to get back to doing everything they want to do. There's no reason to put them through an operative procedure.
So, say somebody is considered a candidate for surgery. There's been, in our generation, there's been kind of changes in how that surgery has been, what kind of techniques we have, because kind of before we started, people used to take out the meniscus. They used to open up the knee and take it all out. There's a problem with that, right?
There is.
Yeah.
Those patients go on to develop severe arthritis.
Yeah.
And that was because there was a lack of understanding of the role of the meniscus. And now that we understand it, you try and preserve as much of the meniscus as you can. And that's where the arthroscopic, when we're talking about an arthroscopic procedure, you're really just making two little puncture wounds on either side of the kneecap tendon, and then you're inserting an instrument that's a camera that's about the size of a ballpoint pen, and allows you to look around the joint. So you're looking through one of these little puncture wounds, and then through the other one you have instruments that go into the joint that allow you to, if you need to remove it because it's in a area that doesn't have a blood supply, you're removing only the as limited amount of meniscus as you can, because just to make it stable and sort of recreate the C shape. Or if you can repair it, you're able to put stitches in through using that similar instrumentation, so that now we don't have to make a little incision, big incisions. We make puncture wounds, and we can do it through that with use of a camera, and even those have changed.
Yeah, our techniques have gotten so good that the tools that we have to create either a repair or the partial removal, have gotten so good that you can really it's a truly minimally invasive procedure.
Yes.
With low downtime, low risk, and very effective.
And done as an outpatient, so
Yeah.
normally it's 30 to 45 minutes to do. Now, if you have other procedure to go with it, it increases the time, but it's very straightforward. And you have the key for most patients after they have a meniscus repair or a meniscectomy is following the instructions, taking it easy the first 3 days to ice it and elevate it, because if you get the swelling down, they're able to rehab quicker, regain motion quicker, and resume more activity sooner.
And what's kind of the time frame? Let's just take the partial meniscectomy where you're removing the torn part rather than the repair, because there's a longer, different
Yes.
rehab protocol there. What's the kind of time frame and expectation for people to get back to pretty much what they want to do with just a simple meniscectomy?
The meniscectomy, a straightforward meniscectomy, most patients, 90%, 95% are back doing everything they want at 4 weeks.
4 weeks.
Yeah, so usually 2 to 4 weeks, you can go back to work within 3 days as long as you're not doing a manufacturing job or something that requires you to stand the whole time. But even with that, it's typically 4 weeks before you're going to allow someone to start repetitive squatting or kneeling or any twisting things, because you're trying to protect what you've done. Even if it's just removing it, you're trying to protect that from any further injury, because that meniscus is still fragile and it's going to go in and the area where you've removed sort of heals over, or scars over, just even with that, from the joint fluid stimulation.
So if you end up having to repair it, what's kind of the time frame there?
Repair is longer because for the first 6 weeks you're going to protect the patient. So you'll have them using crutches during that time. Some physicians will brace a patient, others won't brace, but they say, you have to you're avoiding twisting or pivoting it at all costs. That's the main thing that you're trying to do. And then after 6 weeks, you can begin a regular rehab protocol to assist with range of motion and strengthening exercises.
So the rehab is really more getting over the fact that you haven't
done
been using
anything
it for a while.
Yes.
Yeah. Can somebody go through life with a torn meniscus and do okay?
Yes.
Okay.
Yeah.
Does a torn meniscus cause or potentially cause damage to the joint?
It can. I mean, if you have a big tear, one of the things that you think of, if you have a tear and that area is becoming locked or catching in between the joint surfaces, it can definitely cause further wear of the joint surfaces, and you start to lose the normal function of it. And if we think about it, it's supposed to decrease the stress from the femur to the tibia. And if you've left the area that's torn and that tear starts expanding and getting bigger, like it's going to do in most cases, you're losing the normal function. You have less of that, so that you have increased stress on the surfaces between the femur and the tibia.
Tell me about the one that it's known as a bucket handle tear, but that's the one that tends to lock your knee most commonly, correct?
Correct.
Do I remember that
yes,
right?
That's
okay.
Correct.
Tell me about that particular tear, because there's some more urgency with regard to getting that fixed than just a simple radial tear. Right?
So a bucket handle tear is a tear in the mid-substance. Or it's somewhere in the mid. It can either be in the outskirts but it's a tear is incomplete. So it just tears. It's a longitudinal tear in the meniscus. So that if you think that it's still attached here, it's still attached there. So it's like a bucket handle. A bucket handle can flip in or can flip out. And when it flips in, it typically is going to flip right towards the ACL, or what's called the knot, where the notch is. And when it does that, it blocks your knee from fully flexing or fully extending. Now, if it reduces back into a normal position, you can function pretty well until you twist or pivot the next time and it displaces and then locks your knee. The urgency comes with that tear can continue to extend, and they tend to be some of the bigger tears that you have. So ideally, if you can diagnose that on the front end, you have a better chance of repairing it because of its location. And also you want to limit, if you can't repair it because it's in a non-vascular zone, you want to limit propagation or getting bigger, so that big size doesn't lead to more instability and more loss of normal functioning meniscus.
So if somebody's got a locked knee where they can't straighten it out or bend it, you're going to recommend having surgery.
Yes.
Yeah.
And those are the patients who come in. You can almost diagnose that without even making it to the MRI. You get an MRI mainly for verification purposes and insurance purposes presently, but those are patients that as soon as you operate on them, they think they're feel much better. They're like back to it's total change in of their life. They're much happier and able to get back to doing what they want.
I will say, having had it done twice, my pain relief was almost instantaneous. My knee was sore from the surgery because there's some manipulation there. It's irritable, but the point-specific pain was immediately gone when you finished. And it's quite interesting to feel that profound difference in how I felt. And just like you said, both of mine were not repairs. They were tears that were partially removed. And I was able to get back to running and doing my triathlon type stuff. This was years ago, within just a few weeks.
Yeah.
And it was awesome. It was awesome. Are there any technologies out there? People are talking about injecting stem cells and voodoo medicine to try to repair or cure this problem. Are there things like that out on the horizon that have some promise?
What I would say, people would say that there is research being done about the use of stem cells or even platelet-rich plasma to help augment a repair. Now, would that help in the non-vascular zone? Probably not, because as we talked about. But anything that helps stimulate blood flow is more likely to help with a repair. And and especially in an area, since we're dealing with most of the tears that are repairable are going to be in the 5 millimeter to a centimeter range. They're not huge tears. So anything of that small concentrated area is more likely to benefit from an increase in blood flow or increase in cells that stimulate healing or undifferentiated, like some of the stem cells. But we don't have it. Truly there hasn't been the research nor the studies that would.
And it sounds like right now there's not the holy grail of inject something and it repairs the meniscus. No. At best, right now, stem cells may be helpful in helping a repair to heal better.
Right.
So you're still getting surgery to get it repaired, but they're putting it in there.
Which is probably why in a patient who has an ACL reconstruction at the same time that they have a meniscus repair has a better healing rate than somebody who just has an isolated meniscus tear, because they've got blood, and you brought in stem cells by making tunnels for their new ACL, so you've created that whole a better healing environment.
I think that's probably the theory that a lot of people are working on, but just beware. I think we don't know much, and we talked about stem cells in the past. We don't know much about stem cell efficacy. Is it worth it or not? Right now, there's a lot of people injecting a lot of things that they call stem cells, but frankly, there's not much uniformity in, and it can be extremely expensive for not much data supporting it at this point. I think it's an exciting field. I hope things come of it, because it would be really cool to find something that you can inject into our tissues to help things heal better, but the jury's still out. I think that's probably a fair statement. Anything else we need to know about meniscus tear? How does somebody protect their knees from getting a meniscus tear in the first place? Is there any way strengthening anything like that can help?
I think since most of these have to do with twisting or pivoting, so if you're staying in good generalized condition, doing aerobic, just doing a lot of cardiac work or doing things like that for walking, exercise bike, treadmill, elliptical trainer, and then even working on your quadriceps and your hamstring strengthening and trying to find a good balance, because a lot of the injuries, be it an ACL tear or a meniscus tear, have to do with more of a twisting and an imbalance in neuromuscular control. And that's just knowing where your knee is when you're doing a certain activity. And the more you can do that, the more you do the exercises, the better you're going to be long term. Also, we talk about ideal body weight because of the force between the thigh bone and leg bone with increased weight. So anything that, like For that will help if you're controlling your body weight, and those are the main things. We don't have, if you're going out and playing basketball or any sports, you can cut the wrong direction or at any time, and it can lead to that.
Well, that's how one of mine happened. Literally running in a straight line and just put my foot on the ground, and I knew something was wrong. So yeah, I think it's generalized fitness advice is really what we're talking about, right?
Yeah, but doing that from, it's not just for the 20 or 30-year-old. You want the 40, 50, and 60 and 70-year-old to continue doing that as well.
Cool. Anyway, I think that's good. I think that's the meniscus. So be nice to your knees. When you hear cartilage tear, it's actually the meniscus cartilage. When you hear of bad cartilage in your knee, it's almost always the surface or the articular cartilage. That's arthritis. They are the same word, but they're different structures.
Right.
Anyway, so let's make it a wrap today. Next week, we are talking to Dr. Burton, right?
Oh, we actually don't have a guest next week,
so
you're flying solo if we do it.
Oh, okay. Well, I may fly solo. If not, the following week is when we see Dr. Burton, is it not? Mm-hmm. And Dr. Burton is a total joint replacement doctor, and he's going to talk about revision or redo knee replacement. So I look forward to that. Anyway, let's wrap it up. Remember, go to TOA.com. We can answer a lot of your questions. We can make appointments. You can learn about our doctors and services. We're all over the place. Our practice is growing big, and we can service all of Middle Tennessee and now Eastern Tennessee as well. One thing, this is obviously my opinion, but I think the science is there. I think everybody should consider getting the COVID vaccine. I did. It's the only way that we're going to help reduce the easy spread of the virus. We're not going to control it and get rid of it completely, but controlling the spread I think will help. So consider it. I advise my family and patients to do so. Go out there, stay active, live your best life, have a great weekend. We'll see you next time. Bye.